Welcome to the MedBoys podcast, where we break down the latest in medicine, innovation, and everything in between with the brightest minds in healthcare. Today, we're pumped to bring you an incredible guest, Dr. Samir Grover. Dr. Grover is a trailblazing gastroenterologist and medical educator who's revolutionizing how doctors are trained. As the Executive Vice President of Education at Scarborough Health Network and the mastermind behind the University of Toronto's Endoscopic simulation course, he's shaping the future of medical learning with cutting-edge simulation tech. From award-winning tech teaching to leading transformative education initiatives, Dr. Grover is here to share his insights on preparing the next generation of healthcare heroes. So grab your stethoscopes, MedBoys listeners, and let's dive in to hear more about Dr. Grover's journey. How are you doing, Dr. Grover?
Thanks, Naman, for the super kind introduction. I must say that I'm a fan of you guys also. I was just telling Nimit that I've gone through all of your podcast episodes. That you guys are doing fantastic stuff. So I'm very happy to join, and thank you so much for the kind invitation.
Thank you so much for coming on, Dr. Grover. I'm sorry to all the viewers and listeners for my voice. I'm sure it's horrible, but I'm very happy to see Dr. Grover here today. What first drew you to gastroenterology, Dr. Grover, and how did you know it was the right fit?
So this is kind of interesting to answer because when we are in medicine, we get so fixated to getting into med school, right? It becomes such a major task and such a major accomplishment to get in. But the amount of time it takes for us to go through learning and then finally get exposed to a clerkship which is really like, as you guys have seen in like first 2 years, there's really not that much that tells you what a career is practically like. It's really just year 3 and year 4. And then you are applying after just 1 year of clinical exposure to what's going to be your career for the rest of your life. And like is going to happen to you guys, happened to me already. You have to make decisions really quickly. So the big divide for me was I did a surgical rotation and enjoyed it very much, and I did an internal medicine rotation and enjoyed it very much. And I was looking for something that bridged the divide between the procedural aspects of general surgery and internal medicine, where there's a lot of a cognitive component and planning. And what was cool was that at the time, technologies were emerging such that the worlds between the two were blurring. So we saw that in cardiology, for example, interventional cardiology was taking off around those times. This is like late 90s, early 2000s. But what I thought was really cool was what was taking place in gastroenterology. University of Toronto's medical school is divided into academies, and we'll get to a little bit more about that. And at the time, there were 4 academies that eventually whittled down to 3 and then became 4 again. The 4 at the time included the Fitzgerald Academy, which still exists right now at the Temerity Faculty of Medicine as St. Michael's Hospital. But at the time, it was St. Michael's Hospital, and a hospital that no longer exists called the Wellesley Hospital. Is at the corner of Wellesley and Sherbourne for your listeners who are knowledgeable of the geography of Toronto. And they describe like insular dwarfism and other effects that animals have that are on islands, and the animals become really small, the animals become very gigantic because they have different evolutionary things. The same thing happened with the clinical programs in the little Wellesley Hospital, where this smallest of the hospitals in the downtown core with an academic program at U of T developed gigantic programs in cystic fibrosis, in rheumatology, and in advanced endoscopy. So therapeutic endoscopy, where the use of cameras in the digestive system was not just to make a diagnosis, but to cut out tumors or to drain bile ducts and do things that at the time, and right now it sounds commonplace, at the time they were super cool. And I was based at the Wellesley Hospital because I was part of the Fitzgerald Academy, and I had exposure to a spectacular group of internists that were doing super cool procedural stuff. And that was where I sort of looked at this and said, this is the right field for me.
That's amazing, Dr. Grover. Thank you so much for kind of sharing that snippet into your journey. I guess to elaborate more on therapeutic endoscopy. So obviously it's a revolutionary procedure, but I wanted to know more about how it's evolved during your career and kind of where you see it heading in the next 10 years.
So no one tells you this, or maybe we don't, maybe people tell you, but we don't quite realize it, that when you enter into medicine, the field changes as much as you do. So there are conditions that exist right now that are commonplace. I'm not just talking about things like COVID, but like there's an entity, for example, eosinophilic esophagitis, which is a well-known and described entity of the gastrointestinal tract that was not in any medical textbook when I was going through medical school because of the fact that we contribute to the academic process of creating new knowledge and we get to evolve with the field. That is super cool, right? Like you enter into medicine, the field changes, technologies change, our understanding change. We contribute to that, and we practice in newer environments over and over again. I used to work at St. Michael's Hospital, and when I started in 2007 as a clinical associate compared to when I left in 2023, in those 16 years, it was a completely different world in terms of how the practice took place in therapeutic endoscopy. So therapeutic endoscopy is a neat area which encompasses, as mentioned, the use of endoscopes in order to perform therapies in the gastrointestinal tract. And traditionally we're in the realm of surgery. One thing that's happening right now is really the evolution into training streams that are focused on hepatobiliary endoscopy versus endoluminal endoscopy, because they're very different procedural components, and what's actually being done is very different in terms of those lines. And as an education researcher, you sort of realize that the elements required to teach people to be able to practice in both of those streams are very different. The first hepatobiliary endoscopy is ERCP, endoscopic ultrasound, and now novel therapies that will achieve things through the hepatobiliary system in different ways using other tools that are in development. So, for example, radiofrequency ablation, which was being done for, amongst other things, liver tumors and in the esophagus, can now be administered, for example, to pancreatic tumors, and that would fall into the realm of therapeutic endoscopy of the hepatobiliary pancreatic side. Endoluminal therapeutic endoscopy has been focused primarily around resection and this concept of third space endoscopy, where one is able to create a third space to be able to maneuver endoscopes and administer therapies primarily for resection, but also for doing things like management of achalasia, where the problem is in the lower esophageal sphincter, and one needs to cause a transection of that area inside a place that ordinarily would be able to access with endoscopes. Third space endoscopy has really revolutionized endoluminal endoscopy. There's procedures like endoscopic submucosal dissection and peroral endoscopic myotomy that are, dramatically changing the way that we treat early stage cancers and the way that we treat motility disturbances of the gastrointestinal tract. And again, that skill set is very different than the skill set for hepatobiliary pancreatic endoscopy, and that divide, I think, is taking place right now.
This is all very sorry, this is all very interesting information. And I'm sure as you were going into the field, you couldn't imagine the new technology that's coming out and the new knowledge that you have to gain on a daily basis. It really brings in this skill of lifelong learning that we have to pursue in medicine. But I want to ask you, in your years of training, what moment in your training had the biggest impact on you professionally or through your medical knowledge that shaped your professional direction?
It's medicine is still a very people field, Naman, and it's the people that you meet along the ways that end up having the most influence on you, I think, than concepts, ideas, knowledge, and things that go along. So I want to highlight a few people that I met. Probably the most influential person early on in my training was Jim Kitchens. He's an internist at St. Michael's Hospital and just was the consummate educator. He was my attending on my internal medicine rotation and just had this almost streamlined style in order to deliver multimodal education along the ways. So he had inside a room a nursing student, he had me, the third-year medical student, and he had a PGY3 interested in cardiology. And the case that he was teaching around was valvular heart disease. So he asked the nursing student what an echocardiogram was. He asked me what the physical examination findings were in aortic stenosis, and he asked the incoming cardiology fellow, why do you hear an S3 or an S4 in mitral regurgitation, and does it matter if it's acute or chronic? These were all difficult questions for us. but not super difficult. They were just a little bit difficult where you had to think about it and you were challenged and you could talk to the people around to help answer the questions along the ways. It was so intelligent and so simple in terms of its delivery and ended up being a half hour that, even, 25 years later, I'm talking to you guys about it because it was so ingrained inside my head as a way to be able to deliver information. Later on, I realized that this was an example of something called the challenge point framework in education theory, where when you target the challenge to the learner to an area where they are appropriately challenged to learn stuff, learning will actually take place. If it's too easy, they already know the stuff. If it's too difficult, it's too difficult to even tackle. And this one person in that one teaching session had this tremendous impact just from that. In therapeutic endoscopy, I first learned general gastroenterology, and the mentor I had there was Clifford Ottaway, who's a gastroenterologist who was at St. Mike's as well. And he was interested at the time in gastroenterology, but also in neural networks. This is like 1999. And no one was talking about AI. And the neural network systems he was talking about were basic convolutional neural networks that were developed on the basis of organisms that had developed neural networks in organic processes and trying to translate them into the digital systems that existed now. And he was a gastroenterologist, and he said, well, we're learning a lot about the enteric nervous system. And it evolved in a very different way than the cerebral nervous system. Maybe we could use that as a model for some of the AI technologies that are going to be developed. It was just cool in a very different way of thinking. And he was a cool guy and had lots of interesting things. And he was the first person that taught me to expand your horizons based on what you know and apply them to different fields. And that was a unique thing. And the last guy is the person that probably has been the most exciting person in therapeutic endoscopy in all of Canada and influenced me as well. His name is Dr. Norman Marcon. And he's the father of therapeutic endoscopy in Canada. He's the one that brought every single major innovation in endoscopy in the 20th century into Canada from other areas. And he's the one that taught me that of all things in the world, it comes back down to the patient. Because for all of the cool technologies he was doing at the time in like 99, he was doing something called photodynamic therapy to treat esophageal cancers. And it was super cool. You put a fiber optic cable down into the esophagus and radiated red light, and you pre-treated the patient with photofrin that landed in the esophagus and killed those particular cells. It was so awesome. But then he would call the patient at home after it was done and make sure that they were okay. And he would tell them, if there's a problem, times are different now. You don't do this now. He said, this is my home number. If there's a problem during the night, or if there's problems, you call me. I want to know about it because we could fix this for you. And this didn't just hold for his patients. It held for anybody. He was the most patient-oriented physician I had ever met. And it's funny when I talk about this because he's the most procedural physician that has ever existed in therapeutic endoscopy in Canada. But what I learned most from him was humanity and how to be a doctor. And that is critically important with respect to those people that have those turning points with respect to your life in your medical training.
It's so nice to listen to all those stories, Dr. Grover. It brings me back to my first year, to when I first emailed you, and you graciously granted me a meeting. And you kind of told me all of these things that you were just talking about that other people taught you, and you taught me in your own way. So it was really nice that you continued this mentorship. And that's what inspired me to keep going, look at other fields related to medicine. And that's why we kept MedBoys going. I know you followed us even when we were going on then, and we were super small. So it was really nice for you to say that back then. But it's been amazing to see your journey as well. You've been a clinician, you've been an educator, now you're executive vice president at a big health network. Could you tell us what brought you here and kind of your journey along these years?
So in probably fall of 2022, I was leaving St. Michael's Hospital where I was working at the time, and Young Dundas Square is right there. And there's tons of advertisements that are there. And in the big advertising area, I saw this thing that said, Love Scarborough. and Scarborough Health Network. And I'm like, oh, what the heck is this? Like, we've got a major hospital in the outskirts that's in young Dundas Square in the midst of all these academic hospitals and putting out this campaign. And it was a huge thing. On the video screen that showed up a little shortly after that, they had this beautiful letter to Toronto that they had put across and talked about how Scarborough had some very special things inside its center that were being tapped with respect to its strength. It just needed a resource in order to be able to potentiate that. And it made me think, oh, there must be something special going on here. And then shortly after that, a job advertisement came out for a vice president of education in Scarborough. And that really made me think, well, what is going on here? Like, this is a community hospital, and I'm sure there's education taking place like there are in most community hospitals, but the scope of it was inordinately vast. It contained a collaboration to create the fifth medical academy for the University of Toronto, the Scarborough Academy of Medicine, and to lead as the clinical partner hospital with respect to that project. It included, 44 to 48 medical students per year, which is, the size of a small medical school, right, in Canada. It included potential involvement with respect to education, research, and developing new technologies to support this. And I viewed it as such a tremendous opportunity. And as I learned more about what was going on in Scarborough, I passed by Scarborough numerous times. I went to Scarborough for food because that's where all the good food is, but I didn't know anything about Scarborough. I learned from the CEO, a man by the name of David Graham, who's from Scarborough at Scarborough Health Network, and a colleague of mine named Elaine Young, who's a gastroenterologist who was in my med school class, who's the chief of staff at Scarborough Health Network. And they told me about the unique patient populations that existed in Scarborough, how they described it as, the place where you will find diversity amongst diversity. So it's not just that you have a diverse patient population, you have so many different types of diversity within those patient populations. That was kind of cool. And then the big investments they were making with respect to academics for education and research. And I'm a big vision type of guy, and the opportunity to be able to do something like this, I thought was exceptional. I mentioned I was in Fitzgerald Academy before, so I had an affiliation with St. Michael's Hospital for a very, very long time. I led simulation programs across over there. I had a huge gastroenterologic practice. And it was sort of a big thing for me to be leaving all of that to go, but I thought that the mission that they had was exceptional with respect to education in Scarborough. That's why I came over here.
That's amazing, Dr. Grover. It's clear that you're very passionate about what you do. And as a UTSC alumni, we are, really appreciative of that. We graduated from UTSC back in 2023, and we also volunteered at Scarborough Health Network. I remember sitting at the information desk at Scarborough Centenary Hospital and, thinking about, and that was kind of my first introduction into medicine and to healthcare. And that was kind of similar for both Nimit and Naman. So, thank you for kind of coming here and bringing that level of innovation to Scarborough Health Network. And obviously, to touch more on SAMI, Scarborough Academy of Medicine and Integrated Health, I kind of wanted to ask you more about ways in which you are planning to revolutionize medical education through Scarborough Health Network and through SAMI.
Thanks, Rochelle. I will tell you that volunteer center at the entrance for Scarborough Centenary is on my way out of the hospital. And my favorite thing to do is to speak to the student volunteers and just ask them questions like, oh, are you interested in a career in medicine and healthcare? And you're from Scarborough, and do you know about the things that are going on across over here and what interests you about healthcare? And just the answers are so cool and interesting. A lot of the time it's, family stories and the things you'd expect, but then you'll get things that are completely out of the, like, just like almost like dreamlike and visionary. So one student was like, yeah, so I was interested in volunteering over here because my professor at UTSC told me that there could be a link called knowledge translation between what goes on inside basic science and what goes on in hospitals. So I wanted to learn more about knowledge translation because I'm at school at UTSC and I'm volunteering at a hospital. I'm like, wow, that's a very interesting way of putting it, right? And something you wouldn't expect from a normal student volunteer. So, Rochelle, you've asked about revolutionizing. This is, like, I'm a big picture, sort of like bold type of guy, so I like words like that. I'm not sure what I'm doing is revolutionary, but it's cool. And I'll tell you what the type of stuff I'm doing. So this is through SHN education and through my research lab and what we're building across the Scarborough Health Network Research Institute in one of our pillars, which is based around technology enhanced learning. So I posit that a lot of the gaps that we have in medical education or the things that we do poorly in medical education can be solved by technology that is now caught up with what we are able to actually practically deliver to meet those gaps. So I'm going to give you one example. The example is in assessment. So you guys have heard of competence-based medical education as a rubric. I'm sure even in undergrad, that's sort of entered into the equation. This is deconstructing what the archetype of a physician is in a particular area into certain competencies, establishing what the milestones are with respect to those competencies, and creating a system of entrustment where slowly you get into those roles with respect to those particular competencies as you progress across. And it's been integrated across into various professional streams, including sort of most notably in the specialist stream. The Royal College of Physicians and Surgeons of Canada has this well established. Here's the problem. We actually don't assess very well in medicine. The way that this is actually delivered is contingent upon somebody saying, you did, for example, I'll speak about my field, gastroenterology. You did an interview with a patient with inflammatory bowel disease, but you asked about, many things, but it was a 23-year-old woman, and sometimes fertility is affected. You didn't ask about that along the ways, and here's the ways to introduce that as a conversation, because sometimes patients are, a little reticent to discuss about this to their practitioners. This is something that we very rarely do in assessment for practical reasons. Clinics are busy. It takes a lot of time to be able to do that. You have to be there with the learner across along the ways to see the interactions. I would even posit that in our procedural heavy specialty programs, you could have a surgeon that completes their residency and oftentimes will not have been assessed with respect to the particular surgeries they're doing across all components, which if you told the general public that, they'd sort of be shocked along the ways, but we know this is real. Furthermore, our assessment schema are oftentimes poorly validated. You guys will soon learn about something called the in-training evaluation report, the in-training assessment reports, which are end rotation evaluations, which are just checkboxes. And you don't, there are important things that are described inside there with respect to competencies like medical expert and communicator and professional competencies. But you'd be surprised how many times there's no time to sit down and speak to the learner about how they did, provide feedback, and go check is much, much, much easier. It takes a minute and it's done. And that's usually the way that that this minimal amount of feedback ends up taking place inside academic hospitals. Finally, there's this attachment of assessment to other factors. Like if you get feedback provided to you that's positive and that shows up in a dean's letter, then you're more likely to get a residency position. When really the point of formative feedback should be to make you a better practitioner, as opposed to that other tangible stuff. Technology is objective, and technology doesn't care what program you're applying to and doesn't care what you look like. It will provide you with feedback in a way that is objective and is meant for the real purpose, which is formative. So we are trying to create, very simply put, assessment technological solutions, cameras inside rooms that feed into large language models where multimodal feedback can go inside, microphones that can listen to conversations. All of this is in the experimental stage. We're doing this in sim to start, but have a large language model assess things, use validated schema for, cognitive type stuff, but also like communication. We have schema that are validated for, where you should sit with respect to patients. We have very well validated breaking bad news schema that we can put inside these systems. We even can assess pain by looking at patients' faces, so we can determine whether learners are empathic to pain. And there are even empathy scales that we could use inside systems like this, that we think technology is now at a point that it can assess and provide good quality, regular, and high volume feedback that actually is useful for the learner and doesn't affect them with respect to any other tangible components with respect to their career. stuff like that, I think, is going to maybe not revolutionize, but I think it's cool and it's going to change the paradigm of the way that we look at assessment in medical education. And these are the types of things that we're intending to build across in Scarborough. And the good thing about constructs like SAM-IH is that the and Rachel, I love calling it Sammy also because I pretend that they named it after me. But the good thing about places like this is that they're consortiums of not just medical educators, but it's a large collaboration between UTSC and Temerty, with tons of other affiliated faculties and an interest in how to make practical educational solutions and deliver them into programs. So it becomes a nice way to pilot out projects like that.
Thank you, Dr. Grover. I think it's very interesting to see the perspective of an educator, and actually understanding what possible changes could be made. And it's very interesting to see that still formative assessment is still a very iterative approach, and we're working to improve it on a daily basis. So since you've provided your perspective as an educator, I want you to provide some advice to medical students that are interested in becoming clinician educators in the future. What advice do you have for them?
So, I mean, no, I mean, education is such a different field. Like it's integrated into medicine, right? I actually think that if you are interested in education, you should seek out learning in education as a science and as a field. So there's this surgeon by the name of Richard Resnick. He is former dean at Queen's University, and he developed something in the early 2000s called the Wilson Center. It's based at the University Health Network, and it is a approach to bring education into medicine through various settings rooted in education science. And if you talk to the scientists across over there, they have hardcore knowledge of the social sciences associated with education, the science of education, and how to extrapolate from well-validated learning theories. And this is an entire discipline, and oftentimes we're not very exposed to when we're interested in medical careers. The great thing about podcasts and the great thing about delivery systems online is there's tons of accessible material now with respect to that. There's popular books that are written about stuff like this. So Erickson had a book called Peak that talks about how to develop mastery and skills at a very high level. And it's written for, like, this is where sort of concepts like deliberate practice and things like that sort of were popularized. I'd argue that even some of the more popular books like Atomic Habits and Deep Work and stuff like that are rooted in educational theories about ways that you can learn. So that would be the low-hanging fruit to sort of start, and one can progress onto that into more complex areas and eventually even into studies into education. So to bolster my stuff, when I got very serious about doing education research, I did a master's in education to be able to learn what the science of education was. And honestly, even that is probably insufficient if you want a real serious career as an education scientist in medicine.
Yeah, yeah, and that definitely makes sense, Dr. Grover. I was really interested when you were talking about the LLMs because all three of us are also doing projects related to that. I know these days it's like what everyone talks about, and it's great to see that you're integrating it into something that will make our learning education better. I definitely feel like if there was just a camera overseeing us in an OSCE room, I think that would be a lot more natural than having an assessor sitting there and make it a lot more interactive and real, I feel, which would help us in the real world. I'm sure Rochelle, coming as a second year OSCE's coming up, also is thinking about that. Um, I think our viewers would be upset if I didn't ask you this, but as you were previously involved with the residency program for gastroenterology, or the fellowship program, I should say, what did you look for in a candidate, and how do you kind of decide who to pick when you're put into these positions?
So thanks for asking that, Nimit, because I was the residency program director for the adult gastroenterology residency program in Toronto for 5 years. It was my favorite job until this job. But, at the time, I thought it was the absolute coolest thing in the world because I was building simulation technologies, testing simulation technologies, and now I could integrate them inside. Um, but one of the most important things that I learned was that what you are going to be known for is not the stuff that you do to change the program. It's what your graduates who trained the program will end up disseminating for you. And they're your best ambassadors. So I wanted to ensure that everybody had a fair chance to be able to enter into a residency program such that we had ambassadors that sort of graduated our program, went across to fellowships around the world and trained wherever they ended up training, and were able to be representatives of our style and how we did things. Um, and I wrote about this. I wrote a paper in with a number of colleagues, the majority of whom, I shouldn't say majority, some of whom were trainees at the time, about how to select for GI fellowships. The fellowships being with the American line, something we call GI residencies. Um, there is a large process that was led by Glenn Bandiera, who's an education researcher who was with the Royal College and with U of T at the time that he wrote this, on finding transparency with respect to selection processes. I think that's critical and I think that's necessary. Like when you apply for a job, you need to know what they're looking for. And that was the first step, is ensuring that there was transparency with respect to what the selection criteria was. Even taking a step before that, knowing why we were training gastroenterologists in Toronto was something in our training program I wanted to sort of decide. What was the vision of our training program? The University of Toronto probably trains the most gastroenterologists, but we're probably the most suited program for training academic gastroenterologists. Should we make that overt, and should we integrate that into the people that we select into our program? Those types of questions sort of came up. I even went to the point of thinking that our schema and rubrics for grading candidates should be transparent. You need to know what you're being assessed against. So on our websites and on our, like I had we tried to make it on Twitch, but then nobody came on Twitch, so we just had a Zoom meeting for it type of thing. For anybody who's interested in applying to our program, we basically showed them, like, this is what our grading sheet is, and this is what you're going to be checked off against. And then I wanted a broad scale group of stakeholders, and not just like clinicians. So we had like patients we had nurses, patients, like other stakeholders that you wouldn't typically be, because they're part and parcel, particularly patients of the stakeholders involved in graduating gastroenterologists at the University of Toronto. We were there's a match at the end of it, just like the CARMS match. And my last year, we had a total number into the program in the CARMS match that was equal to our rank list. So we matched our top 4, which I think was probably one of the best accomplishments that I felt that I had accomplished in my academic administrative goals to date.
Yeah, I mean, I think that focus is definitely something that you don't see other programs take. And I think that the transparency is amazing. And I guess to touch on the Twitch point, I used to stream like video games back in the day. Used Twitch for that. So I guess partly because Twitch is kind of a live streaming service for like predominantly video games,
Yeah.
that may be why you didn't get the reach that you would have hoped to get. So yeah, honestly, I think that that perspective that you just shared is extremely valuable. And I think that I just really like that vision in terms of thinking about it in terms of how can you impart to your trainees like what they can kind of disseminate to like other locations, other regions, and to other people, and that kind of will extend the reach of your program and their insights. But I kind of want to take the focus more towards research as well. So you have the Grover Lab, it's at the forefront of medical education, and you talked a lot about technology-based learning. You also, developed this course known as the University of Toronto's Endoscopic Simulation course, and it's a massive accomplishment and a tremendous benefit to all of the trainees involved. I was wondering if you could kind of explain a little bit more about the course and more specifically touch on this idea of mastery learning, and how it kind of fits into the course structure.
I'd love to. So this is thanks for asking this question. When I came on board as a faculty, the key thing I realized was that higher risk procedures were being taught for the first time in the patient setting when technology had caught up to the point where we would be able to simulate and possibly transfer some of those skills so that they were learned in safe, learner-oriented settings before exposure to patients. And that was the genesis for our endoscopic simulation course, dealing with endoscopy, which is the procedure that's done most commonly by gastroenterologists, but also by surgeons and also by pediatric gastroenterologists. And also something that, so GI is a PGY4, PGY5 2-year discipline after doing 3 years of internal medicine. It is a brand new procedure that most trainees will have had limited exposure to before their PGY4 year when they're quite senior, and becomes the broad focus of what the learning takes place in the 2 years of gastroenterology. So it was a high stakes procedure to learn about. I worked with a colleague of mine who was training at approximately the same time. Her name is Catherine Walsh. She since went on to be an education scientist at the Wilson Center. She's a pediatric gastroenterologist. And to your audience, if who's interested in education and is anywhere in Canada, if there's one person that you want to talk to excite you around education science, she is the one person. And she had an almost encyclopedic knowledge of education theories as applied to procedural learning. And together we co-developed a course that was able to translate rooted in core educational learning theories, including some that were developed in Toronto, how to teach. And the theory that was rooted in Toronto was done by a colleague of mine named Ryan Bridges. It's called self-regulated learning, where if you as a learner take on the intrinsic and metacognitive aspects of what your training should be, are thoughtful and think about your performance, or use technology to help you determine what your performance is, and then change and alter the way that you're performing based upon that, you will end up performing better in procedures. That was our hypothesis. And the course became the way that we were able to test out to see whether these things actually made sense. Progressive learning was our first thought process of bringing education theory into this setting. So what we did is we did a very, very simple study where we took half the trainees that were part of our course and trained them on a system where we assessed them. And when they had reached certain benchmarks, MPS, minimum performance standards, then we progressed them on to something that was tricky and challenged them. We measured what their level of challenge was, and we allowed them to complete things from basic simulators all the way to high fidelity simulators for endoscopy. And we compared that to a group that got a same amount of training, but didn't have that progression. And then we tested them in their first colonoscopies that they actually did in the clinical setting. And we saw a tremendous difference, a statistically significant difference in the group that was trained with progression, suggesting that this educational theory actually was valid in this setting and transferred across into the clinical setting. And that's the model system we started using. Going beyond minimum performance standards is the concept of mastery learning. So as opposed to reaching that minimum standard, if you train, simulation environments are a great way to practice until you get really, really good at something. And I was telling a student that the best people at doing endoscopy in our courses aren't the residents going through the process, but it's the the summer students that we have inside our programs, because they're just playing on the games all the time. And they just practice. And they're the ones we call when we can't do something on simulators because they're the best at it. It's like a video game. You get really, really good with deliberate practice. Simulation-based mastery learning is essentially that. It's learning to a standard beyond the minimum performance standard, which is equivalent to mastery, and ensuring that mastery is achieved. But the point is that it should be achieved in all domains with respect to the procedure, some of which are technical and some of which are non-technical, and some of which are integrative. So we wanted to ensure that we were also teaching things like patient communication during procedures. So for example, in endoscopy, you need to be aware of, patient vital signs, to be aware of pain thresholds and things along those lines. Oftentimes you diagnose things like cancers, and then you have to be able to tell patients about that afterwards. We wanted to incorporate all of those non-technical skills as well as part of our strategies. And it's a lot harder to train to mastery in some of the non-technical skills. One way that we trained on how to do that was trying to turn even that into a game. So we have a gamified curriculum where I let the students design it. So they wanted to go Drake theme, so they called it Starting from the Bottom and had a game board with a picture of a colon while you progressed across. But we wanted to try to gamify some of the non-technical elements as well. So that you were gauged on your performance in terms of communication or leadership inside a team-based structure along the ways. So there are many different ways to use various education theories, including mastery learning, inside a very simple procedural construct to be able to augment learning. I thought that was super cool.
I think this is all very interesting, and I think it's being put to the best use. I want to take you back to
One thing before you ask your question, Naman, let me just turn my camera. So this is the back of my office, and I don't know whether you guys can see all of the certificates and stuff. These are all the posters from the course from the 14 iterations that we've had the course, and the signatures of all the students who sort of love things along the ways. And I think like part of my ethos is trying to keep things fun and keep things cool type of thing. And I think that's super important as well when you're creating simulation courses. It's cool using technology. It's fun. And keeping things sort of within that spirit, I think is the most important thing beyond any other education theory.
well,
Sorry to interrupt.
I don't know. That was very interesting. I want to ask you, what do you think are the qualities that separate a good trainee from a great one? I know you've mentioned the aspect of an educator, but I want to hear more about the learner perspective as well.
Uh, I'm going to say it doesn't matter. I give you, I'm going to embarrass him by saying this, but so my first research assistant that I had a very poor track record in undergrad and had a really poor GPA and didn't really want to go into medicine, and then got interested in medical education, was doing a master's, and then wanted to work with a project that my colleague Catherine Walsh was working on, but she didn't have the course was being run at St. Mike's at the time, so I got attached to him along the ways. He really liked the way that we were doing stuff with technology. He joined our lab as a research assistant in 2013. And then he's smart, very, very intelligent, and was creative and came up with lots of ideas that I didn't even think of were possibilities in terms of studies that we could do, and progressed along the ways to the point where he decided that he wanted to be able to apply these more directly into medicine and gastroenterology and wanted to reapply to medicine along the ways. But he was cast off. In 2011, he was told, there's no way in the world you're going to get into med school type of thing. And then he got into medical school, to Queen's University, a med school that I didn't get into, and has graduated. Now I'm going to become a gastroenterologist and going to be able to do this sort of stuff. So I think, I think our definitions of what are good and what's great, I think are so flawed, and I wouldn't view them as sort of being that important, because I think there's stuff that I really suck at and there's stuff that I'm really good at, and the alignment of what makes you passionate about something, I think, is the most important thing as a trainee. So if you are passionate about something, if you really, really like something, odds are you're going to be great at it. Odds are you're going to be creative and you're going to think about things in ways that nobody else is doing, because you're looking at this stuff yourself. You're on the internet looking at different ways of approaching things because you're really, really into that. So I would say that what makes a great trainee is passion about the area that they're training in.
I remember a time, Dr. Grover, when during our meeting, I was trying to elicit from you basically the same question. What should I do to get into residency? Should I do research? Should I know my specialty in my first month of medical school? And you'd said the same thing to me. You'd said, just chill out and just calm down. Things will fall into place. And I was very perplexed by it at the moment. But then I realized that you were right. This year, when things kind of started falling into place, when I stopped thinking about things, and I expressed that to you in the email asking about this podcast. So I know people will be like, it doesn't matter is like a very general statement, but it's actually extremely true. Since you talked about keeping things fun, we'll end this podcast on a fun note. What is the most fun thing you do on a daily basis?
The most fun thing I do. I do, so my whole life is I try to bring fun into so many different things. So my office, you'll see toys and all the stuff that I like along the ways. I am on a standing desk right now with a walking treadmill underneath me. I was going to start walking on the treadmill because I try to make Zoom meetings as fun as possible and just doing little things like this. The most fun that I have these days is there's a lot of travel in medicine, particularly academic medicine. You go to conferences and meetings and stuff. And I love traveling with my wife, and my wife comes along with me to conferences, and then we take trips by ourselves. And I really like, I didn't come from a super affluent upbringing, so this is really my first chance to sort of explore the world and see the world, and I find that to be probably the most fun thing that I do now.
Thank you so much, Dr. Grover, for everything that you've told us today, from your career journey and motivation to gastroenterology, to your journey through education and leadership, to your passion for medical education and research, and to end on kind of your personal insights into mentorship and growth. It's been an amazing sort of podcast and episode and conversation with you. So on behalf of the entire team, thank you so much for coming on today and to, imparting your wisdom onto our audience, who hopefully will be inspired to follow in your footsteps in medical education or even gastroenterology.
Pleasure's all mine, guys. Thank you so much for the invite. It's been very enjoyable talking to you.
Thank you so much. Until next time, guys.